Hello, today I'll be doing my lightning strike presentation on labral tears and intervention options. So my Pico question is in male collegiate baseball players that have labral tears that are candidates for surgical intervention. Does surgical intervention or conservative measures lead to higher return to play rates? A little background on post-operative treatment plans. They include three main factors are going to include strengthening range of motion as well as proprioceptive training. On the strengthening aspect, there's going to be a high focus on the biceps brachii, deltoids, and rotator cuff muscle group, as well as a secondary focus on the latissimus dorsi, teres major, and pectoralis major. After 1 week of post-op, you're going to be focusing on isometric exercises, and then after 4 weeks post-op, you're going to be incorporating light resistance training. Once your main muscle tests are 4 or 5s out of 5s, that is when you can then incorporate free weights, TheraBand, bodyweight exercises, as well as machine exercises as tolerable to the patient. And the natural progression is going to be about 5 pounds every increase, as tolerable. Your range of motion for weeks 1 to 4 post-op, you're going to be limited to 30 degrees of external rotation. And weeks 1 to 6, you're going to limit your external rotation in conjunction with abduction. And then you're going to incorporate a range of motion plan to increase your range of motion. After 6 weeks, you're going to be able to incorporate joint mobs grade 3 and 4. And your progression is going to be based off the patient when there is an elimination of pain, apprehension, and abnormal movement pattern for whatever range of motion you're trying to focus on. Your proprioceptive training can be both closed and or closed kinetic chain exercises. And some examples include plowback ball toss, unstable surfaces that you're trying to hold yourself on, as such in the middle picture, or catch and throw exercises. And then conservative treatments. One thing that I've found in my studies is that they really focus on the incorporation of soft tissue manipulations such as massage, active release, or gastron technique. And then Blanche et al. Reported in his findings as he looked at surgical options, surgical post-op treatment plans as well as conservative treatment plans, is that they mirror each other very similar in that it's a strengthening range of motion and proprioceptive training. Aiden et al. Did a study on slat lesions and those that performed only conservative treatments, and the return to play was successful, but the return to overhead throwing was not. A little bit about return to play is Gillam et al. Did a study with 246 with slat lesions that tried conservative treatment, and they all failed and required surgical intervention. A rock climber with a diagnosed slat lesion by imaging had 4 PT sessions of conservative treatment and canceled his further treatments because he returned to his normal at a rate that he could actually perform at a higher level than before. In a study with 133 that had slat lesions, 64 returned to play and 36 did not return due to pain, decreased range of motion, or inadequate performance. In that 64 that returned, 13% were forced to change position group to performance, and in that 64 again, 8% required additional surgery. So there's technically an 8% fail rate for the surgery in that study. Based on position group pitchers, there was a 59 return to play population, and then in the study that of that 59%, 41 reported in a follow-up review that they were at the same or better capabilities. In the other positions, such as catcher, infielders, and outfielders, 76 were able to return to play, and 64 reported that they were at the same or better performance level. Some reasons for not returning are decreased performance, weakness, pain, stiffness, or tightness. Changes in clinical practice. Changes in clinical practice, I would incorporate a 4 to 8 week conservative treatment plan. And in that 4 to 8 weeks, I would also be setting up the appointments with a physician to pursue a surgical route. One thing I noticed with my last rotation is many insurance companies and or physicians like to have proof that the patient is performing a conservative treatment plan. Whether this be to 1, rule out the need for surgical intervention because this solves the problem, or 2, just to show that they are working towards towards a solution. So in that 4 to 8 weeks, again, I would be setting up the appointments. The other thing to note is the position or the players preference and kind of where the player is at. So what I mean by this is if the player is a freshman and they have the rest of their high school career or their college career, or maybe even the intent to go into the majors, that yes, I would support the conservative treatment, and if that does not work, the surgical intervention, as well as supporting them in their post-op treatment plan. If a player is at the end of their career, such as they're at their senior year and they have no intent to continue, it'd be worth having the conversation to see, are your symptoms manageable by the conservative treatment plan, other means to include NSAIDs or other means, that is surgical worth it? As we saw, there is technically an 8% fail rate in this one study that I read. So is the risk of the surgical intervention, does that outweigh the symptoms being managed by other means? If they are manageable and there is no intent to move on, maybe it is worthwhile continuing a conservative treatment plan and not pursuing a surgical option. But again, that's based on that's a case-by-case kind of conversation that you need to have with the athlete and talk to the athlete to see what their point of view on the situation is. The best thing to do is be able to present them with the current information and be able to show that the conservative treatment, we should try this. If that fails, move on to the surgical intervention if that's what the athlete chooses. Ooh. And here are my references.